Well, good afternoon, everyone, and thank you for taking the time to join our D2D webinar, Sharing Strategies and Successes and Secrets. This is our fourth progress update. Next slide, please. Remember that our stated goal is a 25% reduction of scheduled medications in long-stay patients. What we're providing, and I know many of you are using, our tools, support through the AMDA website that we've been laying there. We know that you're using them. So if you're new to this process, please visit the D2D website. Tremendous tools there for you. Next slide, please. So where we are, this is the December webinar. Was the appropriate use of benzodiazepines. So we went into how they worked, how you use them, non-drug strategies and tools to target anxiety. That was very interesting. And strategies to deprescribe benzodiazepines safely. Next slide. For today, this is the participation webinar. Every other, this is the participation webinar. We really want to hear what you were able to do with benzodiazepines or anything else. And so the chat function will be available to you at that time. Next slide. The objectives today are as they always are: identify successful strategies for deprescribing, discuss common barriers and solutions to optimize medication, and describe opportunities to participate here in the Deprescribing Office Hours. And we've got a great presenter for you today. Next slide. Sabine.
Yeah, hello. Alicia, you can drive that slide down now. Hi, I'm Sabine von Preis, co-chair of the D2D initiative, and I'm really pleased today to introduce you to my AMDA or WAPELT's friend, Jason Heffernan. Jason is a family practitioner, hospitalist, really, really good medical director and post-acute and long-term care specialist. He works with Team Health, and he is a medical director for one of my facilities at Avalon. But he also is the regional medical director for the West Coast for the post-acute and long-term care teams, and he has 8 states under him. And when you have finished listening to him, you will understand why he has so much responsibility, because he really has a lot to teach all of us. Jason, you and I and the Avalon Medical Director Group have worked for over a year now on medication optimization and deprescribing. And we've made good progress, especially with sliding scales. And then Omnicare presented me in one of our quarterly corporate meetings with data on benzodiazepines and trazodone. And I was shocked to see that we had thousands of prescriptions of these 2 drugs. And being that I am a CMO, I gave that right back to the group of capable medical directors. And you really shone, because the next time I looked, and I think that was a month later, you had made significant inroads. I think over 50% reduction of benzos and trazodone in your facility. And I would like you to talk a little bit about what was that experience like? How did you achieve it? And then also talk a little bit about, as regional medical director for Team Health, where did you carry that experience? How did you carry that experience on, and what your activities are? So Jason, let us know how did you do it?
Well, thank you. You know, first I'd like to say that if only I did it myself. I think that the first thing to say is thank you to you guys, and how these webinars are impactful on what we're doing out there. So I think that's the first key, is that people like you are out there making it a known point of education for everybody. working with managed care programs and everything over the years, I've always been surprised at, it's always easy in the moment to say, oh, we've got a fix for this, but then you look at your own backyard and realize you've got some work to do yourself, right? And so I think whenever you educate somebody, you have to look at yourself, see what works for you, but also understand overlying themes. So one of the things that we've done, especially through Team Health, is work on quality metrics. So we have a quality metrics program that is a tool for providers. So that's the first thing we did, is we looked at, when we're giving quality metrics to our providers, how are they utilizing them? And then how do we focus on something like a benzodiazepine? So giving them the tool to have an insight look that is readily available to the provider has been essential in keeping them involved in the process, as well as being able to hold them accountable. So we want to be able to go back to the providers as a whole, and we want to say, what are you doing about this? And if you need education and support, here's the education and support. And that's when we can direct them to places like AMDA. That's when we can direct them to self-created education materials in regards to benzos or other medications that are affected in this push for polypharmacy. So specifically with the anxiolytics, and I guess not just as specific, but was to first realize it wasn't about me. It's about the provider team that's in the facility. It's about the provider team underneath me, and it's about what they're doing. And things have changed in our world of healthcare, where we really are approaching care more as a team and less as an individual. And that's exactly what I started with. I went to my team and said, you guys, let's talk about what's going on in the facility. How many of these actual medications that we have in front of us do we feel are warranted and appropriate? And I was kind of surprised at the response I got, that in fact, the providers didn't feel like a lot of the medications were really that appropriate, but they were something that either the patient had become accustomed to, the family had felt it was appropriate, other people had somehow it had gotten on there, and it just been, that's what they were on. And so there hadn't really been some discussions about some of the more specific medications, such as benzos. There's been some laziness in our rounding procedures, and that's where you talk about progression of care in a post-acute space. And I really preach this a lot to our providers out there: is what is your motto? What is your gestalt on progression of care in the post-acute space for those patients? And it's got to include examining these medications that are creating a lot of problems for patients out there, and in the end, creating polypharmacy. So how do you start a new admission or a long-term care patient in the process of progression of care? How do you address that anxiolytic or that depression med or that pain med or any of those things? It can't be, hey, I'm Dr. Heffernan, or I'm so-and-so. I'm your new provider. You've never met me before. Now trust me, I'm going to DC a bunch of things. So you have
That's a good point.
Right?
That is a very good point. That's our conflict, isn't it? We don't really know these
huge
patients.
Problem.
Yeah, that's a huge problem.
And so
how do you deal with that then?
So that's what we did, was we sat down with our providers and we said, let's go over these meds first. Let's identify the ones that you've had the conversation with. Once we identified the ones that they felt were inappropriate, or the ones they felt they had not had the conversation with, I said, go have that conversation. Went back later on and said, how did the conversation go? We had, it was an interesting, percentage. Some patients said, yeah, I don't really use it. We gave them information like that. We looked up how many times it had been administered in the last month, so that we could go to the patient and say, look, you're on Ativan. You've only used it once in 2 weeks. Was there something else we could have done that would have probably gotten you through that episode and not had to put you through all the ramifications of being on Ativan, all the side effects?
I love that. Just that sentence, you just took it. Is there something else we could have done? What do you think?
Well, and that's part of the second process, right? And that's not why it's just ourselves, is we looked at the facility and we looked at our partners in the facility and said, what could we have done, right? Why is this patient receiving Ativan, and what happened there? So our providers went in with a really thoughtful conversation with facts. we didn't go into the patient's room that uses Ativan twice a day or 3 times a day and say, let's get rid of Ativan. But we did go in the room with patients that use it once a month or once even a week and said, what's your trigger? Is it after a phone call with your mom and dad? What's going on here? What can we do to alleviate that problem? And what we found was a lot of people were open to getting rid of a benzodiazepine if they had a plan for what would happen if they did. It wasn't just a, we're going to get rid of it. It's, we're going to get rid of it and provide you with some support to get you through that event that led to you using it in the first place.
Well, Jason, I think that is so important. And we in our last webinar talked about the non-pharmacologic interventions that in no other medication category is that important. And it looks like you've done a lot of the ultimate patient-centered question. What is it that we can do for you in this situation? So great.
Well, and then after that, it was, I sent the providers who had the best relationship, right? The APCs really, I mean, they're the ones that really build that tight relationship. They see them the most a lot of times. Now, if you're an individual provider in a facility, that's you. But then when they came back and said, okay, let's go over them again, and we looked at that list, there were people that said, no way, even though they only used it once a week or once every other 2 weeks. And that's where I said, I'm gonna come in with you. And we approached it as a team there, and I approached it with the MD, right? And said, look, this is really why I'm concerned about you on this medication with the lack of utilization. And we found that we had even more success at that point with that group of people. And by the end of it, which, you know, it's interesting is that in November, the last report of information we had, we actually got down, we had 5 people on anxiolytics in the building.
Right.
You know, so we're down to we're actually down to a 4% utilization rate of anxiolytics in that facility. And that includes, you know, just the benzos. So there might be a boost bar or something like that on there, but that was our focus at the time. So I think when we talked, we were at about a 15 or 16% utilization rate in the facility. Now, maybe that was only 4 or 5 or 6 people. I don't, you know, off the top of my head, maybe it was 8, but there were 8 people in the building that really didn't need the med, and we haven't restarted them. You know, we haven't had to go back and restart. So that team-led approach, but then the facility was a huge part of the solution because, to your point, we didn't just go in there and say, you know, you're getting off of this. We went to the facility and said, this is what's triggering their anxiety. What can we do as a team to help? And they came up with some very good, you know, ideas in regards to how to minimize that Ativan utilization or trazodone. Really did a lot of sleep hygiene discussion with the facility, talked a lot about how, you know, different things that were going on that were upsetting the sleep hygiene of the patients and why they were stuck on trazodone or felt the need to. And I think that helped when we were able to go in and say, we know it's difficult to sleep in the facility sometimes because of A, B, or C, and this is what we're doing to try to minimize that.
So really involving the patient, acknowledging their physical problems, but also giving them the feeling and really acknowledging that you are trying to actively work on that.
Hey, Sabina, can I ask a question?
Absolutely.
We have an expert here, and there's a lot of questions coming to mind. Jason, thank you for sharing your story. I always like to, which I call it, to kind of dispel the overestimation we have usually in our minds about the barriers we'll face from the family when we start the prescribing. And honestly, in my own personal work and the work which I've done with my teams, I think we do overestimate the barriers family may put in regards to deprescribing. Could you just talk a little bit about what your experience was? Of course, if we know from literature, there is a certain proportion of families who are going to be barriers because they really believe in those drugs and they think they're really helping. What was your experience specifically in that regard in the prescribing initiatives you've led?
Much more open than like you said. You know, really in the end, what the families wanted, what the families experience and perceive is the patient calling and saying, I'm having an event, and the family wants immediate assistance, rightfully so. You'd want it for your mom and dad, somebody to do something. What they needed to hear was, there's ramifications and there's problems that are associated with this kind of use, especially intermittently, right? When we're only giving it to somebody once every 2 weeks, that's the day they fall, right? So there are consequences to utilizing that. They wanted to hear similar things about, well, okay, if we're not going to do that, what are we going to do? And what's the plan? Once you gave that to them and you educated them on this, that these aren't just really benign medications that we're handing someone, this isn't a multivitamin, this isn't anything else that, that they think of as, well, they need something. They actually were very open to making changes. And a big part of it was having the patient voice, they were ready to make a change. So that was something else that I think was really important, is having the patient on board with it. Before we had the family on board with it, almost made a bigger difference in a lot of that, because we could say we spoke with them. They feel like, this is going to be a good thing for them. And here's why. I think that helped a lot for the ones that couldn't speak, the demented, the cognitively impaired, the memory stuff. That really does come down to really getting with the family, making sure they understand that we're treating a behavior that doesn't need to be treated with this, and we need to change our behavior as a healthcare system. That makes all the difference in the world for them. I think they want to hear what we're going to do, though.
Well, I certainly love that you fully prescribe to the principle. It's not about taking something away. It is really about giving them something better and healthier. So thank you so much. Dr. Hamelwitz, you can ask a question.
Thanks, Sabina. Can you hear me?
Yes, I can.
Okay, I have a question about this. A weird thing happened at one of the homes that I work at, where the consultant pharmacist made a recommendation to stop unused medicines that haven't been used for 90 days. And the response of the physician was declined because the family declined. Now, I think that's so weird, because like what I do is if somebody hasn't used them for 90 days, I would just stop it. But have you seen or heard of such a thing?
Do you want me to answer that? Because
you can answer it. Anybody else can answer it.
Yes,
I think there's an answer to it, and that's generally, if you go back and get into the nitty gritty of it, my guess is the provider didn't speak to the family, and that's probably what warranted the family saying, no, we don't want anything done with it. That's the key of this, is communication. And so I think if I got that report from a pharmacy, because I watch this, and that's something else I didn't mention, is as a medical director, I actually go through the med list once a month for the patients and look for what you're talking about. So if I can pull up, their med list, look, and if I identify one that looks outside of what I would normally prescribe, I go and look and see whether or not it's been administered in a recent period of time. So I'm proactively doing those kind of things. But if a pharmacist were to call me, the first thing I would do is I would communicate with the family before I DC'd anything. I think the mistake there is to DC it, have the family react to it. They put up their barriers to that because they're not educated on it. They don't even know if the patient's been using it. If somebody would have called provider-wise and said, this hasn't been used in 90 days, there's really just no efficacy. And by the way, if they do become in a situation where they do need it to be restarted, I am going to do that. That's something else they need to know, is they think once you take it, you're not going to give it back. But to your point, Dr. Von Price, it's prescribed to the need, right? To the medical necessity. So that's what I'm going to tell those patients and the families. That's my guess in why you would hear a response like that from a family on a report.
Well, it always kind of bothers me when we kind of make decisions, when we put undue pressure on the families to make decisions when they have no business making those decisions, right? I mean, can you imagine a surgeon putting in their note that this patient came to me with acute abdomen, and they really needed an acute appendicitis-based surgery, but based on the daughter's request, I'm just putting them on IV fluids and Cipro. Like, no, we only accept families' input and advice when it's there, if there's room for that. But I mean, if we clearly see that a patient is gonna not benefit from a pill, man, we are stopping that pill. But yes, we are being very respectful. We are being forthright, and we are being proactive in those conversations. We just cannot get them lagging behind in a reactive conversation, because then we're not going to build trust and they're going to hate it, right? So good comment, Jason. I really agree with that.
Any other
And-
questions? I see Deborah Millet saying it happens all the time that families are. So I think that families decline those deprescribing interventions. And I
I think they
think
should say no to us though, right? That's the key. Say no to the provider, and I think you'll have a lot less no's.
that's true. Yes. It's easy to just shove that off to the nurse and yeah, what you call the family, and then and the nurse may not even know why. So, you know, there's an opportunity, if you want to do that, there's a definite opportunity to also educate the nurse and maybe say if they have more questions, the doctor can call you back. I mean, that might be another way of dealing with if you time pressed. Sometimes.
So I just have a quick question, Jason. So good, you know, I mean, I know you put a lot of work into this, and you know, it takes energy, and you build momentum, and then you get some good work done, like you did, and it's very inspiring. But you know, medicines are like weeds, right? I mean, you're gonna turn your attention.
I love that.
3 weeks later, I mean, that's the example we use in our company. And 3 weeks later, you turn around and you come back, there's like a whole bunch of them again. So how do you keep the energy going forward? How do you set up a cadence? What lessons did you learn so that you then can set better processes at team health or that building? What do you do with this, what you learned, and how do you set up more systems so that this continues to be an ongoing, not just one-time initiative?
Yeah, so a couple different things. That's a great question. The first is, for Washington State, the quality metrics program has been absolutely a game changer in regards to sustainability. Anybody can have a quality metrics program. The question is how do you design it to be consistent and sustainable? You put resources to it, and so that's what we did in regards to that. Is we put resources that are dedicated to making sure that the providers are getting regular feedback on what their outcomes are in that facility. So that's the first thing. The second thing is I feel like I want to coin the phrase, you know, but it's not a new phrase, but I've like grown to love it, is the progression of care model, and teaching the APCs and the team how to progress a patient through a facility from day one of admission to the day of discharge is a key answer to what you're saying. So that is where I start to say, how do you deal with insulin sliding scales? And what does that look like? How do you deal with anxiolytics? How do you deal with antipsychotics? How do you deal with even antiemetics, which people don't give a lot of credit to what a dangerous medication an antiemetic is. But anybody on this phone call or on this webinar who has had a patient phone call in the middle of the night that said, so-and-so threw up, they're dehydrated, they're confused. And then you go back the next day and say, where did this start? And they say, well, 4 days ago, they started getting nauseous, but we had an antiemetic. So we started giving it to them. They haven't eaten or drinking for 4 days. They finally got to the point where they actually got sick from it. And now they're back in the hospital system because we didn't get rid of a PRN antiemetic that hadn't been used for 30 days prior to that event. Had we done that, we would have gotten a phone call from that facility and said, hey, this person's not eating and drinking. They said they're nauseous. I would have went and seen them and said, this is something different. This is a little more malicious. So
you put the nail on the head there. I think PRNs that are unused are actually a safety problem.
Absolutely.
And you know why we have so many, why we have that culture of these unused PRNs? Because of medicine in nursing homes before the year, I don't know, 1990 or 2000, when the provider really would be in once a month.
Yep.
And they did not or could not respond. So the nurses had their own little pharmacy, their own little smorgasbord of possible PRNs they could use for whatever situation. And those days are behind us.
Right? But you have to teach the providers in the facility even how to get rid of a sliding scale. You just don't DC the thing. That would be dangerous. So you have to really talk to them about day one. How do you assess a medication regimen for the dangerous medications on that list? And what are you going to do with them over the next 7 to 10 or 14 days to make sure that they're not lingering 21 days later for no apparent reason. And that fits the same thing with long-term care, teaching the providers, when somebody has an acute event, what does that mean? Well, in today's age, with as complicated as these post-acute patients are, it means you got to treat them like they're in a hospital system almost. You got to treat them like an acute event, like they're a new admission to that facility, and you got to progress them back to their normal state of health. You can't just see them once, write a note, order some meds, and then hope that you got it right. So it's about progression of care in these buildings, in my opinion.
Well, I love that term, progression of care, and I'd love to talk with you some more about it. Maybe not in this webinar, but that might be another very interesting webinar.
Well, we, sorry to, I just want to say, like, I really love this term, and, we call it care paths, but it's really having proactive strategic care, which is so critical, what you're talking about. Yeah, I really like it. Sorry, Sabina, go ahead, please.
No, I absolutely think it's a great term and a great concept. It's not thinking in the only today, but where's the trajectory of the patient? What are your goals for this patient? And you put it to the post-acute model, but it is also a long-term care concept, if you think about it. So we have one question here from Deborah again. Can you give some example of the QMs you are using? And you talked about the benzos, what other things? And when he gives the examples, I know which ones they are. They will be all very familiar to us. So just
it's kind of funny, is we tried to purposely pick things that we thought would drive providers in different, even we track antiemetics. Why are we doing that? Because I want to drive providers into, because none of us like red, right? None of us like to be said, you've got a bad grade or something. We don't like red, and we don't like bad grades, and we don't like that stuff. So, but how do you get them to engage in that, and also not DC everything on the day of admission? Because some providers would rather look good than, end up with the best outcomes. So, it's easier to DC the sliding scale on day one than it is to progress them off of it. So we picked parameters, and we picked metric points that we felt were reasonable and would drive providers to not over deprescribe, but appropriately deprescribe. And so we did things like insulin sliding scale, antipsychotics, depression medications, opioids. Obviously, I've mentioned the antiemetics. PPI is one of them, which reduced PPIs to almost nothing in the state, which was really an interesting effect, because I didn't have all my facilities, everybody didn't all of a sudden have reflux. Let me see, I'm trying to think, 30-day readmission rates, though total readmission rates. We've got a fall metric that goes into place now. Even Coumadin, we put Coumadin on the metric protocol. And what we saw was everybody got, for the most part, now we have people that only should be on Coumadin. And nice. What happens to your point that's so important is, like weeds, 2 months later, somebody shows up to the building on Coumadin and they shouldn't have been. And now we're catching it so that we can get rid of it. Maybe it's a delay of 30 days, but instead of it being 6 months or 8 months or a bad outcome, we're at least catching it in a 30-day window now. That's been very helpful. But that all goes back to that progression of care model, where you're teaching providers to identify all those big quality metric medication problems or issues, and learning how to deal with it from day one, or an acute event. Because gone are the days where you order Lasix and then forget about it, and 7 days later they're over diuresed and nobody's told anybody, right? We gotta get into
yes,
that.
I wish
How
those
do you
days
order
are gone.
Lasix
Yes,
on a CHF patient? Right?
Yeah, that's not how we should practice anymore. Well, it's been just a fantastic experience to listen to you. Yeah, I say bravo, and you are really, I think, have it down how to deprescribe and how to do it correctly. And I'm lucky to have you as one of my medical director, and your team being part of my medical director team. So if you have any more questions for Dr. Heffernan, feel free to put them in the chat. And Alicia, if you could put on the Next question, and the question, we have a couple of polls, but the first question we are asking you right now is, what success did you have deprescribing benzos in your center? If you could just put it in the chat. And there is no wrong answer, by the way. Did I say that? So let's see whether we get any answers in the chat yet. PRNs are reassessed regularly and all have an end date. Love it. Wonderful. That's a regulation, but it still doesn't always happen, does it? Dana is asking, do we have alerts for health meds such as blood pressure parameters to prompt providers to consider discontinuing meds? You know what? I think that's a great idea. I don't know that I have that other than a verbal alert, or when I look over the medications, I look at low blood pressures. Does anybody have that baked into the EHR, an alert? Or Michael, have you, Michael Sinkler, are you aware of that? Yeah, that would be good. That would be good to have. Let's explore how technology can help us. I have in PCC, I use the non-used medication within PRNs within the last 30-day module. There is, but it's on the dashboard. Not everybody has that though. And Colleen says she has some success if the family is involved. So with benzos, probably particularly important. All right, let's go to the poll question. Which classes of medication have you been most successful in deprescribing? You can, if you have had many successes, you can select all. But maybe you want to just select one. So those are PPIs, multivitamin, anticholinergics, antihyperglycemics, and that includes sliding scale insulin, benzos or other anxiolytics, and then anything else that you've been successful at. Please go ahead and put your answers in the chat. And we really want you to answer that so that we know where we need more education, where we need to look at more education, maybe more tools, how we can help you better. Multivitamins is the winner. That's an easy one, isn't it? It's the one that I particularly like because from my pregnancies, I remember how terrible multivitamins were. But anticholinergic and sliding scale insulin, excellent, and some benzos. So I think
I'm very impressed with PPIs.
Yeah.
That's impressive.
Yeah, good. Okay, now of course comes the next question: which one were challenging to deprescribe? And then if you could, once you, so can run that poll, please, Alicia. Okay, great. So it's the same ones. Any of those were challenging to deprescribe. And the reason we put these particular medications on there is because those are the ones that we have covered so far. And then if any of these were challenging, if you could share a why in the chat. We love the chat. Chat more. Oh, interesting. So multivitamins seem to be once again the winner. And anti-hyperglycemic, sliding scale insulin, and benzos and other anxiolytics. Interesting. There's true anxiety due to COVID. I can't staff buy-in about reducing anxiolytics, benzodiazepines. benzodiazepines due to family and patient resistance, mostly due to behavioral fears. Okay. Families are reluctant. Yeah, so it sounds like there is a lot of family concerns around benzos. And Jason, you talked about that in how you address the family concerns.
Yeah,
What
I
was
really, I can really relate to Laura's comment there, guys. I mean, oh my God, you work hard deprescribing medications, and the patient goes back to the hospital for whatever reason. The hospital has their old EMR medication list, and they put the patient back on everything you deprescribed. That's a very, very big frustration. So thanks for sharing that.
That's the weed aspect of meds.
Right.
The roots are still there.
Jason, were you, just a question about, I'm focused on the comment where they come back. Is part of your strategy that some meds like benzodiazepines, they're there in your Omnicell or whatever pharmacy e-kit or box that you have? Does that play in that we can stop this med, but if we need it, it's there? Is that part of a strategy?
That's been a huge benefit. I can't tell you how many people just want to know that if they need it, it's there. And if this doesn't work, it's not going to be the end of all. Like once I take it away, it's not like, ha ha ha, I've got it now and you can't have it back. I think that's been a huge thing for all it gives them a sense of control. It gives them a sense of the fact that you're acknowledging that there is a reason they're taking it, and that there may be a need in the future for it. But right now you're doing okay and you're not using it. I think the fact of whether or how much they're using it has been by far the most helpful thing, is digging into how often and why. And to the point, Dr. Von Price made a little bit ago, unfortunately, when you let the nurse or staff make that phone call, sometimes they really do misspeak, not intentionally, but it happens where the staff, the staff says, well, they're pretty anxious, but the doctor wants to get rid of the anxiolytic. And all of a sudden that's done. They've heard that I want to get rid of something despite I've lost all credibility. So that's why controlling that conversation, not for all of them, we don't have enough time to call every family member for every medication we want a DC, right? But for the big ones that we feel really are kind of, just flat out dangerous. I think if we did a study and tried to figure out how many PRN medications are involved with not being given for a long time, and within 24 hours of them being given, the patient fell or got hurt or something bad happened, not because the med did it necessarily, but because something was going on that we weren't notified to in a lot of cases. So I think that's the knowledge and power that really helped a lot. And then us intervening to take over that conversation for the big stuff.
Thank you, Jason. Michael, do you want to take it from here?
Sure. So as we've come through our process of our D2D process, we did some reflection over the past couple of weeks, and what's working well for us, what would we like to work better. We are asking you for your feedback. What would you like us to cover? And one of the areas that the things that we're going to be bringing forward is we're calling it the spearhead group. So when we look at our data, we have 3 pharmacies, lots of centers that have contributed with those pharmacies. But what we know is that not every one of those facilities or centers are engaged, right? And so, when we looked at our new data is coming in for last quarter, but when we looked at the previous quarter, there wasn't a big move. And it occurred to us that some of that is we're measuring everyone, whether they were engaged or not. And so what we thought we would do is, we know that because we know from the folks we talk to here every month, we know within our own organizations, there are facilities and centers with phenomenal polypharmacy or scripts per patient numbers, that there's a lot of great work being done. And we want to pull that out and bring these centers forward, look at them as a group, maybe get them more involved. So we're calling that the Spearhead Group. And these are centers that we would identify, but we would like you to volunteer. If you're doing great work and you'd like to be part of the Spearhead Group, please reach out and let us know, and we'll be working with you and others throughout the rest of this year as a way to augment what we've been doing, maybe get a little bit more fine-tuned and show you some better overall results.
So Michael, how would they get involved and reach out? How would that practically happen?
You know what? That's a great question. I think what will, Erin or Alicia, maybe we could actually put your name in the chat box.
Yeah.
And thank you. Put your name in the chat box, and we will reach out to you. We'll also put something on the D2D website.
Yeah, you know, in the follow-up email we'll send you, we'll give you an opportunity there to kind of connect with us on that. So I mean, so you may not be willing to put your chat name in the chat box as of yet. So we will give you an opportunity through the follow-up emails to let you know how you can connect with us. So it won't be hard to find us, believe me.
No.
Exactly, and we really want to know about your successes, and they may not be successes everywhere, but maybe just the one can just really develop its own momentum, and we'll all be better off it if we know about it. So I really would appreciate if you communicate with us about your successes. All right. We are almost out of time, but we want to indulge in yet another. Hey, we are into the polls this time around. We'll do another poll, and that is about what you would like to see next. There's a lot of medications out there that we haven't even touched on, and in order to kind of make sure we meet your needs, which medication topic would you like to see addressed next? We just threw out a few that we thought that we know are a problem. Paxlovid, yes. I'm not sure that is well, maybe we should talk about it. Maybe that's more for grand rounds. But Carolyn, I am with you there.
This is the best group to talk about it with.
Yes, why not, right? Yeah. So, okay, dementia medications is the winner, and antipsychotics, and those two really are kind of a group. And I think this is I think this would be a fantastic topic, dementia medications, to go next and look at that in detail. Who we should, because there's always, and speaking of family involvement, it's quite emotional to discontinue a dementia medication potentially. So why don't we...
Dr. Hamowitz brings a good point, is specifically the systematic issue of how transitions impact unnecessary medication. So I think we can insert that conversation in any of the talks going forward. That's a huge issue.
That's the weed part. Yes.
Yeah. Right,
I know all about it. Maybe we can sneak in Paxlovid somewhere there too. Although, good thing it's not that available yet, so we're not using it yet.
And then Shelley is saying simplifying blood pressure regimens rather than being in low doses of several different, like, yeah, that's a big one. The nurses would love us for that, right? I mean, if we just, instead of giving 3 pills at half the dose, if we could use 1 or 2 instead, you know, that's just a win-win situation. And then Dr. Hammer was saying the issue of matching medications to patients' goals of care has also been difficult for me. Yeah, so no, those are all good thoughts. And I think some of those can be inserted in any conversation going forward. So we'll keep track of those good ideas.
Plenty of topics to discuss. Yeah. Plenty of topics to discuss this year. Excellent.
All right, I think we're right at time, Sabina.
All right, perfect. Our next webinar is February 17th, and with March 17th is the scheduled progress update. Right now, I don't even know. I don't think that interferes with the AMDA conference. I hope we checked on that, but let's just keep February 17th in mind. We're really looking forward to have another excellent presentation and giving you the tools, showing you how to deprescribe the next medication we choose, and addressing some of these other topics that came up today, like the whole thing of a weed. I just love that image. It is so true. That's pushing through. And well, it's after the annual conference. Okay, so we're all energized after the annual conference and want to do better, and we'll give you the tools. So Erin, did you want to talk about the Polypharmacy Learning Collaborative?
I think we actually have somebody online that's participating in this.
Oh,
Alice,
okay.
are you on, or anyone else?
Yes.
I
hi.
oh, sorry. Go ahead, Jane.
Okay. Yes. Hi. This is Joan Guzik, and I'm the Director of Quality and Efficiency at the United Hospital Fund in New York City, and we are a not-for-profit organization, and we've recently received a grant to sponsor a learning collaborative with 6 nursing homes in New York City to address polypharmacy. So if there are any organizations that are participating in this drive to deprescribe who are in New York City and are actually, they do need to be not-for-profit organizations, because we are able to provide grant money to support participation in this project. And we envision this as a year-long collaborative. There will be some focused learning sessions. We have clinical faculty that will be available for coaching, and organizations will be implementing specific interventions and collecting data. So for those that may be interested and fit this criteria, Alice Ehrlich, who is our Senior Program Manager, her contact information is on the slide. You can reach out. We do expect to issue a request for applications next week. So if you're interested in receiving such an application, or if you would like some additional information, you can please reach out to Alex. I'm also putting my information in the chat as well.
Well, thank you, Ms. Ehrlich. I think this is, I'm looking forward to you reporting maybe from your initiative. I am excited about that. Deprescribing and medication optimization are taking off. And with that, I want to thank the AMDA staff for having this great discussion. Special thanks to Dr. Heffernan. Dr. Heffernan is going ice fishing today, and he made a special stop here for us at D2D on his way to go to ice fishing. So we appreciate you that you that you gave us this on your coming day off. So thank you so much for your thoughts and your great contribution to the effort and to our D2D initiative. And we'll see you in a month. And until then, be well and deprescribe and optimize. Bye-bye.
Bye, everybody.